Hi, everyone. So my name is Sarah Remberg, and I wanted to welcome you all to Headway Foundation's first webinar, the Eye-Brain Connection, Vision, and Concussion. Today, we're lucky enough to have Dr. Bryce Appelbaum joining us. Dr. Appelbaum is a neuro-optometrist who specializes in the evaluation and treatment of vision problems associated with acquired brain injury. He's a board-certified fellow of the College of Optometrists in Vision Development and is the clinical director of Appelbaum Vision. He has worked with patients and athletes of all ages and skill levels, including myself, and he is here today to discuss the ocular motor system and how it is affected by concussion. So thank you for giving us your time today, and we hope you will learn a lot. All right, so Dr. Bryce, what is the ocular motor system and how does it work?
First of all, thank you for having me here. It's an honor to be part of the inaugural webinar series, Headway Foundation. And hopefully this is fun for everybody. So the ocular motor system refers to visual tracking and specifically eye movement and coordination ability. And when we think of tracking, there's really three main eye movements that we make as humans: fixations, pursuit, and saccades or saccades, depending on how you pronounce them. Fixations are really the ability to kind of quickly and accurately look at something. Pursuits are our ability to visually follow an object that's moving, so keeping your eye on a ball or a puck. And saccades are really jumping our eyes from point A to point B, as we do in reading. But I think the big take home, not only just about the ocular motor system and how vision is impacted from head injury, is really that if you understand the difference between eyesight and vision, then you have a much better understanding of how vision gets impacted and the symptoms that ensue after a concussion. Eyesight is what we all get measured when we go to an eye doctor. It's the ability to see letters on a letter chart, to see what's on a street sign, in the classroom, to see what the teacher writes on the board. And eyesight's important, but that's what most people have contacts or glasses for to help correct. Vision is much more complicated. Vision is entirely in the brain. And it's how the brain gets the eyes to move together, to focus, to converge, to track, to really process information. And vision is really what gets impacted from concussion. There's really never or rarely an issue with eyesight that's really just temporary. Vision is what gets impacted. Vision is a learned process. It's a process that as babies and infants, it's not developed, and through our life experiences, we learn how to use our body, both sides of our body together to integrate both sides. We also learn how to use our eyes together. So vision can either be learned well, or in some cases not learned as well as it could be, and that's when we have a developmental visual delay. Or vision problems can be acquired, which is really what we're talking about here with concussion. Because vision's in the brain and it's intimately woven throughout the brain, it's really impossible to have a head injury and not have vision be impacted. That's kind of crazy to think about, but I mean, sometimes the impact is at a very, very minor level, and sometimes it's at a devastating level. But in my opinion, vision is always impacted. And in fact, there's really more areas in our brain dedicated to processing our vision than there is for all of our other senses combined. So it makes sense that with a sudden acceleration or deceleration of the brain stem or the brain matter, that at this microcellular level, there's concerns. I don't want to talk too much about neurology, but I think the main part of our brain we want to think about with vision is our frontal lobe right behind our skull. The frontal lobe is really one of the more complex areas of the brain. It helps carry out motor behavior, including those saccadic eye movements that we have to accurately make. It's in this area that we deal with working memory and behavior and navigation through crowded environments, and how all those areas can be impacted symptom-wise, which we'll get to in a little bit later. Here also is the vestibular system, and where the visual and vestibular system, more importantly, kind of connect with each other and get all the information and input from the balance center in the back of the brain. I bring up vestibular system because a lot of people with concussions do see vestibular PTs or have a visual vestibular disconnect. And a lot of people are probably thinking, man, what is this vestibular system? I hear about it, but I have no idea what it is. Real quick, it's kind of like when you're at a mall and you see one of those maps in the center of the mall, and it says Nordstrom's over here and Macy's is over here and the food court's back here. And then there's this red star that says you are here. And in my opinion, that red star is us, and that's our vestibular system letting us know kind of where we're located in the roadmap of life. And we'll talk about how that gets impacted as well from some kind of trauma or changes to the brain. Take home note about the ocular motility system, your initial question, sorry to come back to that. Usually and almost never is it an eye muscle strength issue or an eye muscle length issue. It's purely coordination and how the eyes are coordinating together as a team.
So how is vision specifically affected by concussion? Like what are some common issues post-concussion that you see in your clinic?
Gotcha. So think of a concussion as a major or minor bruise to the brain. And vision symptoms are common, and most vision problems because of a head injury can in fact be treated, and in many cases treated very well. So the problems that occur really stem from kind of the integration between our central focal visual pathways and our peripheral ambient visual pathways and how well these are working together. And what that means in layman's terms is kind of knowing where things are, what things are, and how to process visual information in our environment, having all of the processing occurring in a parallel fashion. So one of the common syndromes associated with concussion visually is called PTVS, post-trauma vision syndrome. And with that is usually a cluster of diagnoses and symptoms. The diagnoses typically have to do with exophoria or exotropia. So what that is kind of a mismatch between where we perceive things to be located in space and where they're located. So actually having our eyes aligned behind a page rather than on the page. Decreased depth perception or 3D awareness. Accommodation dysfunction, that's the muscles inside of the eye that control how clear something is. And when our internal focus of our eyes is impacted, obviously the cognitive focus associated also becomes impacted. Convergence insufficiency, the inability to keep both eyes and the sweet spot of both eyes coincide on the same place in space for long enough to actually see a single clear image. And additionally, also problems with low blink rate, which can cause dry eye, spatial disorientation problems. The list kind of goes on, but those are the main ones. Symptoms associated with those: double vision, eye strain, headaches, with ocular motor system, tracking problems that would be skipping lines, losing your place, repeating lines, having the words separate or become blurry, and potentially problems with judging space, depth perception, concentration, balance. So really think of it as mainly the daily tasks that previously we could do when we were just on autopilot require all of a sudden all of this kind of conscious attention to do.
So if I were a patient, because we have a lot of patients joining us and parents of patients, what are some of the symptoms that might lead you to believe that a vision problem is causing the post-concussion symptoms as opposed to something else?
Good question. Well, I would say I think there's an interesting research article that came out saying about 10 to 20% of concussions actually result in symptoms that can last as long as months or years. So the key is no two concussions really look the same from a clinical presentation or from an anecdotal presentation, but there are a lot of symptoms that are very common. Reading difficulties, skipping words, skipping lines, words moving on the page, not always just related to the ocular motility system, but very common. Kind of fogginess, blurriness, light sensitivity, headaches, eye strain, a feeling of kind of visual sensory overload. You probably know a lot of people who, after a concussion, can't go into a mall, grocery store without feeling incredibly overwhelmed. And it's just there's all this information, this flood of input that the brain has trouble processing and filtering, and a lot of times it can set the patient into a panic and have a lot of scary emotions associated.
So, a Children's Hospital of Philadelphia study found that 69% of pediatric patients are diagnosed with a vision problem post concussion. So, I was one of those people, and I can attest to the fact that, um, having a vision problem. So, if I was in a mall feeling dizzy, walking through a grocery store, getting nauseous, looking from my notes to the screen of a computer or a smart board in the classroom, the inability to read and remember what I read, things like that. So vision therapy is what played a hand in my recovery and perhaps the most impactful rehabilitation option that I tried. So would you walk us through what is vision therapy and how does it work?
Absolutely. So it's neuro-optometric vision therapy. It's a specific area within optometry, neuro-optometric rehabilitation. Really think of it as kind of physical therapy for the brain through the eyes. And as optometrists and neuro-optometrists, we have the ability to retrain our visual brain to change how somebody is using their vision to decrease or eliminate symptoms. So what it is it's you know creating a period of kind of disequilibrium for some people, or breaking down bad habits, but then putting together stronger, more efficient ones where we're raising awareness, what they're doing, how they're seeing, how they're processing, so they can self-regulate, self-monitor, and then eventually do these visual tasks, integrate them with balance and movement, so that they're able to meet the daily demands of their life. We're kind of facilitating recovery with vision therapy by engaging the brain, engaging the areas that have been suppressed or kind of dormant, equalizing the skills between each eye so that the brain doesn't have a choice over which eye to use. It's using both eyes together as one unit. Um, and it's really kind of desensitizing and rehabilitating the visual system, but in most cases, just like any therapy, it requires a lot of motivation and compliance. You're working either with a doctor or under the direction of a doctor who's hopefully board certified in vision therapy and rehabilitation by COVD. We put a big emphasis on home activities on top of office activities where we're teaching certain skills, excuse me, and then we're giving the patient ways to practice these skills at home. And with any newly learned skill, it takes a lot of practice before it becomes habitual. But vision is very often a missing link in terms of tying together all the other treatments and rehabilitative therapies that a patient's undergoing. And in many cases, kind of a roadblock that prevents somebody getting back to their pre-head injury self.
So to sum it up, it's essentially using repetition to teach the eye-brain proper function. Thank you. So this is a hot topic in the concussion world, and that's diagnostic technology. So how does vision play a role in diagnostic technology because it is so prevalent post concussion? For instance, the King Devic test.
Absolutely. Well, I'm preaching to the wrong group here, but you don't have to be unconscious to have a concussion. And in fact, a lot of patients don't even know that they've had a concussion when they've had one. They can't be detected on MRIs, or most MRIs. And more often than not, externally, the person looks fine and normal as if nothing happened. And so it can be frustrating because it'd be wonderful if there was this clear test that said, yes, you've had a concussion, or no, you haven't. And there's a lot more clarity to the situation. Neurologically, what radiologists and neurologists look for is DAI, diffuse axonal injury, and there's really one specialized type of MRI that can pick that up, and it's looking at the flow of water molecules along the different axons in the brain. That's almost never used and never really gets to that level. And so there are a lot of, like you said, a lot of tests that specifically use vision and localize vision to tell whether something has changed or whether there is a decrease in performance. The King-Devic test, which you mentioned, is wonderful. It's simple. It's economic. It's a great sideline concussion screening test. It can sometimes take as little as 2 minutes to complete. It involves eye movements and rapid number naming. And so you're looking, it's tapping into some of those connections in the brain that we talked about before with the visual pathways, but also with language processing. It's highly sensitive, highly specific for detecting concussions and help determining neurological functionality. And essentially, you're having somebody read a bunch of numbers, and they're organized in very specific fashions. They read the numbers, you time them. If there's an increase in errors or a decrease in time in terms of how long it took them to go through the test, uh, something has happened, something has changed. So this is a great objective screening test for removal from play and a great indication to say, okay, you need to go be evaluated by a trained professional. Um, because it can be used by non-medical personnel, it's great. I mean, we have parents of toddler soccer teams administering this test if need be. And so it's something that has become a really nice gold standard in a lot of different communities, leagues, and even professional ranks. Also looking at vision, there's the SCAT test, the VOMS test, the impact test, basically a lot of tests that are looking at vision and particularly visual perception and processing to detect change. We also have, with trainers, looking at pupillary reflexes, looking at computerized cognitive testing measures, looking at electrophysiologic testing, looking at high-tech tracking devices. But I think the key is vision is a really important window into exploring what's potentially occurred in a concussed brain.
And going on, so you mentioned using these testing sport and using vision as a screening tool in sport. So how does the ocular motor system affect sport performance? Why is it so essential to assess vision before potentially returning a player to the game?
Well, athletes clearly have to be able to see the ball, but more importantly, they have to know where the ball is and be able to anticipate where it's going to be. And a key to kind of optimal visual performance is that simultaneous processing I talked about before between central and peripheral input to allow us to know, have the knowledge spatially of what's occurring on the field, court, rink, in our environment. Ocular motor system allows us to know when actions are happening, where they're happening. It allows our brain to control our eyes, but more importantly, our vision to then guide our movement and our bodies. And so they're critical to performance, especially in sports, because the optimal and precise control of these movements can allow an athlete to really slow down the game, to better prepare themselves to react to visual information more efficiently and quickly, and to be able to anticipate where they need to be, where their teammates are, where the opponents are. Because, with a concussion, you can see the ball, but you really can't see the ball the way an athlete needs to. And so I think it's a great system to really be accurate with our intention.
So there's this statistic that if you get a concussion, you're more likely to get another one. Do you think the vision or the ocular motor system plays a role in that? Because if you aren't visually acute and aware of your surroundings, then you're more susceptible to a second impact.
Absolutely. I mean, I think a proper vision assessment from a developmental or neuro-optometrist will look at the ocular motor system for sure, but also peripheral vision, depth perception, binocularity, speed of processing, knowledge of coordinate field, understanding of plays, being able to see whether vision is helping or interfering with somebody's ability to perform at their potential. athletes in general are at a higher risk for injury than non-athletes. And with each concussion, like you said, we know we're at a greater risk for further concussions. And some studies will say that, if you're not removed initially after a suspected concussion or after concussion, the recovery time is dramatically different. So it's imperative for the safety of the player and frankly, everyone else around them. If, it's imperative to look at vision to know whether somebody needs to be immediately removed to not hurt themselves or others.
So when a concussion does occur, because they will happen, and someone comes to vision therapy for an ocular motor dysfunction, what should they expect?
Good question. So it's, I think, like any process that it requires a lot of work. It requires a lot of wanting to be there and wanting to kind of face the music, essentially, because it does require work to kind of come out of this dark place for a lot of people. But an evaluation looks at all the systems and looks at whether these systems are working appropriately independently, as well as them integrated with other body systems. And then in therapy, it's a matter of addressing each of these systems at the patient or person's level of functionality, and then kind of pushing the envelope and allowing them um, to seek the changes and make the changes to have their eyes, body, and mind work more efficiently together.
And then, so what are some of the tools you use in your office? Do you use a lot of prisms, and what is your rationale for using that? And that'll be the last question before we take some from the audience.
Good question. So not every concussion case requires vision therapy. In some cases, there are specialized lenses or filters or prism glasses that can be used to help decrease visual stress and make it so that the activities of daily living and the near demands are more doable. But in a therapy setting, we're using a lot of lenses, which are forcing the patient to stimulate their focusing system or relax their focusing system to improve flexibility. We're working with Prism to help them converge, understand near space better, diverge, understand far space better. We have a lot of very high tech equipment with virtual reality and computerized programs. We also have a lot of very, very low tech equipment. So the key is the patient's engaged in active learning, learns from the activity, not just learning how to do better at an activity. If they're learning from it, they can then take what they're learning, transfer it to other activities, and eventually to improvements in life outside of the therapy room.
Great. So now we'll be taking questions from the audience. Are there any sex differences in vision between men and women?
Women are the far superior race. I will say that in general. I would say it's more independent to the individual rather than anybody else. The type of injury and really where we are. But in terms of basic visual skills, there can be differences between men and women.
So what is visual snow? Is it frequent, and how is it and is it correctable?
Visual snow is scary and a very common symptom that a lot of people experience. A lot of times it's related to the accommodative system, so the internal muscles that control clarity with our external world. And a lot of times it's kind of an overflow of peripheral information because our focusing system can't attend to detail at near. In many cases it's improved, in many cases it's eliminated. There can be anatomical problems from a head injury where there's different cells or matter floating in the brain or in the eyes, that are creating this kind of snow illusion. Of course, that's not treatable with therapy, but a lot of times that integration of central peripheral information causes, the misintegration causes some of that snow phenomenon.
Thank you. One person asked, are there eye recovery exercises on the internet or YouTube that we can do at home?
Well, you can Google anything on the internet and find a ton on there. I would say there are certain activities that are generally good for eye movement control, convergence, and different individual systems. in many cases, it you don't really learn from it. It just makes things maybe different, but not necessarily better. So I think if you go to covd.org or visionhelp.com, there's a lot of information about different research, patient testimonials, but also activities you can do at home to help. But I think a lot of times you need to figure out first, you need to identify uh, where the problems are occurring, what systems they're involving, and then whether the route is more important to start with vestibular PT or alternative care or medical care or nutritional care or vision care. But activities wise, there are some. There's a Brock string that you'll see if you Google stereo Sue, and there's a lot of different explanations on how to use a Brock string. But a lot of times you need I would say in most cases, especially with head injury, you need the guidance of somebody who's trained and know what they're doing so that they can kind of teach you through and around certain strange symptoms that you'll notice if you have had a concussion with visual problems ensuing.
Where can someone learn more as an athletic trainer to help train athletes with vision to help prevent concussion? So vision as a preventative measure.
Good question. There's a wonderful website that the Vision Health Group that I'm a part of just launched in the past year or so called concussionproject.com. And it's a website we dedicated to just informing the public on concussion and the visual problems that occur. There's a section that says for individuals, and there's a section that says for professionals. There's a lot of information there on how to better educate yourself, and also continuing education courses are out there. I would say in the last couple years, vision has become a hot topic in the medical community, and you're starting to see a lot more neurologists and physiatrists and primary care doctors even understanding the visual component, knowing what to ask for, what to look for, and knowing how to refer to the right person. But if you don't do these tests, you're not going to be able to find a lot of these problems.
How do you deal with frustration levels from patients about the healing process?
The frustration problems are real and they're there, and it's I would say you got to feel like you're in the right place with any type of treatment, but it's something you go through together with the team that's there to support you. And for every person, it's a little bit different. Whether they need a more hands-on approach, whether they need a more pushing the envelope approach, whether they need more of a let's communicate and share a lot about what's occurring. But I think what's really special about vision therapy is every activity that you're doing, it should be based off of the previous activity. And the level of demand should be increased and can be adjusted for every activity so you engage in higher level thinking and learning from what it is you're doing. So there should be a really healthy communication between the patient and doctor or therapist, because if that communication is there, then you have a great foundation for support down the road, because there definitely will be highs and lows. It's not an overnight fix. But I would say, you're not alone, and you're in this with everyone who's there to help you.
Yeah, and speaking as a former patient, as one of your former patients, in terms of communication is key. The more that you talk to your doctor, the more that they know and can help you. And that vision therapy gives you an objective tool. It's almost like practice, which is really comforting to an athlete taken out of their team, because it's training. You go in and you put in the work, and then you see results. As long as you continue to work hard with someone who knows what they're doing. So with regard to frustration, a great couple deep breaths is really useful. And then also seeing how far you've come. If you look back a year ago where you were a couple months ago, a couple weeks ago, and seeing that progress and being attentive to the little victories can go a long way in keeping your morale up. So someone asked, how many people who work with you end up 100% symptom free?
Good question. I would say, in my mind, that's absolutely the ultimate goal and the ideal goal, but it's not realistic for everybody. I would say I like to at every progress evaluation, when we're assessing both objectively and subjectively where the patient is, I go through every symptom that they shared they experienced initially, and we go through, is this better, worse, or the same? And we get to a place of stability first and foremost, and a place where we're visually happy. And then you look at all the systems, you see how stable the foundation is, you see whether the processing and eye movement control is in fact at an unconscious and automatic level. I would say most people, if not a very high percentage of our patients, do get to the pre-injury level with enough time and motivation. And a lot of people get to a place where they say, you know what, is no longer interfering, but maybe it's not helping me. And for that person, that could be a great endpoint. So it's really should be independent to the person, but we want to make it so vision is not getting in the way and hopefully helping them in life.
So for someone who has post-concussion symptoms for more than a year, is that less likely for them to then attain a full recovery?
I don't think so. I think it's a lot more embedded of a maladaptation, and the longer you allow a lot of these symptoms to go, the longer the problems become your normal. And really, a lot of what our brains do to adapt is we adapt or we maladapt. And so, we see patients who are 5, 6, 7 years out after their concussion, and I honestly don't know how a lot of people get through their daily life. Time, I think, is not necessarily a limiting factor, but I want to see somebody as soon as I possibly can to assess where they are, so that we can at least get data points at a minimum of knowing their trajectory and the progression they're on. But the whole rest and relax and everything will get better on its own. I'm a big believer in let's decrease the recovery time and increase what we can do happily.
So what should one look for when looking for a neuro-optometrist or a neuro-ophthalmologist?
I would say you definitely want to go to make sure on their website or in talking with them that they do treat traumatic brain injury and concussion. To me, the important distinctions are that they are board certified, so that they have the letters FCOVD next to their name, which means they're a fellow of the College of Optometry and Vision Development, or also there's fellows of NORA, so FNORA after their name. You want somebody who has proven that they're capable of diagnosing the problem, treating the problem, but more importantly, as the patient, you really want to feel comfortable in that environment. So, it's not uncommon to see patients who come to us for second or third opinions. In a lot of cases, it's kind of an alternate opinion, not necessarily a second opinion, because Sarah, you can attest to this. Most people have seen many, many doctors and specialists before they've seen me or someone like me, and in rare cases, that's not what happens. But you gotta keep listening to yourself and keep searching until you find what makes the most sense for your recovery process.
So the COVD certification is an important thing to look for, because that means they specialize in the vision therapy for vision development. And I believe the COVD website has a database where you can put in your zip code and find a COVD registered doctor near you.
Yeah, in the upper left-hand corner, it says locate a doctor. You can type in address, zip code, state, country. It'll list all the practitioners within a certain radius. You can set the radius. You just want to make sure if anybody's on there, they're better than, or they understand vision in a different way than a normal primary care optometrist. But you want to hopefully see somebody that says FCOVD next to their name, and then you're in good hands, at least for the evaluation.
And then Jeff might have my favorite question of the day. So how do upper cervical issues contribute to vision problems following concussion, and what should be addressed first and how?
How long do we have to talk for this?
Keep it to a couple minutes. But okay. Jeff, you get a gold star.
Good question. So I would say a great analogy of a adult patient I was treating last evening she said, when I first saw you, it felt like my head was a bobblehead. and it was just wobbling around, and I had no stability or support for anything visually, but really for anything with my brain. And upper cervical issues cause a lot of instability to that foundation that supports our visual system. I mean, we have, even from a medical standpoint, 20% of our optic nerve fibers don't leave the back of our eye and go to our brain. They actually go down your neck to different postural mechanisms. So, you need to have a stable foundation, a stable core to be able to support the high-level binocularity and eye teaming that we need in life, not only for sports and driving, but even for interpersonal communication, for work. Vision is a very intricate process, and because it's interwoven throughout the brain and throughout different postural body mechanisms, instability anywhere in your body can impact vision.
Do you believe TDCS is a promising vision therapy tool for concussion? So why don't you walk through what that is as well, please?
So there are lots of different testing protocols out there. I would say there are some that are more common than others, and there's some that are have more research behind them than others. And I would say no one test should really be used in isolation. I think you need to really do a lot of different testing procedures, look at the big picture, make sure everything makes sense, confirm an objective test that's in free space with an objective test that's on a computer to make sure, or to see where the problems lie. But I think a lot of neuropsychology does a great job at looking at the higher level visual thinking skills that are impacted from concussion, and then are starting to actually look at eye movements and eye teaming skills and convergence. And so definitely better than not doing that test, but I would say that with a thorough vision evaluation would be ideal.
Great, thanks. So one question, this comes from a patient. So she's 3.5 years out from her concussion, and a year and a half ago she got Prism glasses, and they were a huge help, and this person loved them. But they're worried if they continue to up the Prism, then there's a question of dependency. And then would vision therapy help? What else would it be addressing? If you could talk about the difference between just giving someone a Prism and actually doing the vision therapy.
Absolutely. So for some people, Prism glasses can be wonderful and life-changing, and can make a computer less terrifying to look at. And for others, it can do almost nothing. And for others, there can be a big adaptation that takes place. So essentially what Prism is Prism is a optical device that moves visual space. So we can move something that's in front of us to the left, to the right, up, down, and any angle based off of how we orient the prism. If somebody has an eye turn or a strabismus, let's say the eye is 10 units out. And it's 10 units out whether the eye is pointing up or down or left or right or close or far. Prism can be great in terms of moving the visual world to where their eye is. But I would say, especially with concussion and brain injury, almost never is what you find consistent throughout the day, when fatigue sets in, when visual demands change. And because of that variability, in a lot of cases, there's not really one Prism value that eliminates the problems. And I would say the big negative with Prism, although they can be very helpful in decreasing symptoms, you can adapt to that Prism, and that can become, instead of therapeutic, more compensatory. And then you're adapting to that lens, that becomes your new normal, and then you need a stronger Prism or more movement of visual space to elicit the same response as before, and then you kind of eat it up where it's getting stronger and stronger. So, I mean, in an ideal situation, I'd much rather teach the patient what to do to fix the problem rather than have them rely. But that's not always an option, and in some cases, Prism can be helpful.
This person says the main problem is vertical phoria.
So vertical phoria, so I mentioned earlier about exophoria. Exophoria is the eyes aligning behind the plane of regard in visual space. Vertical phoria is kind of the z-axis, or excuse me, the y-axis, so one eye higher than the other. So the direction of the phoria to me doesn't really matter a whole lot, because it's essentially saying there's a mismatch between where we perceive things to be located and where they are located. Other than with a vertical phoria, we have less eye muscles controlling vertical fusion, and we have less life experiences watching things go higher and lower, so we have less control usually of vertical fusion. But just like any phoria, you can adapt to the manipulation of visual space, and then need something stronger or different to maintain the same response.
All right. What is the difference between the COVD and NORA?
Different organizations. I would say COVD is an organization that specializes in vision development. So from an acquired problem or a developmental delay problem, I think it's a broader spectrum. Whereas NORA is neuro-optometric rehabilitation, and typically that's just for brain injury. I would say most people are involved with both, but I think COVD is, in my opinion, has a much more thorough fellowship process and a really nice quality of control that allows you to know that if somebody is a fellow of COVD, I would trust them I would tell the patient they would be in good hands. NORA is just a different, less expansive organization.
On average, how often do patients go to vision therapy?
Good question. That depends, I think, on the practice. I would say for my practice, most of our patients are either once or twice a week, with a big emphasis on home therapy. We also do a lot of intensive treatment or kind of boot camps, where patients will come in from out of state or out of country and do a session every day, 2 sessions a day, sometimes more than that a day, to get as much done as quickly as they can, because they're either that desperate for progress, or that's what they see as the best option. That doesn't work for everybody. So especially with brain injury, it's very, very easy, as Sarah can attest to find your limit and to push you over the limit. And the key is that you always find your threshold, stay below it, but are always kind of raising it. So if we're doing too much in a finite period of time, that can have a lot of negative impact. So I'd say most patients are once or twice a week, with as much as we can do at home. A lot of people, we recommend 10 to 15 minutes of practice a day, of good quality practice, and then at least 1 day off a week. But it should be individualized to the person and kind of tailored to their goals, symptoms, and what's occurring clinically.
Right. And the last question is, how do you prioritize different therapies if you have a PCS situation with multiple symptoms: balance, vestibular, heart rate, autonomic, fogginess, tinnitus, vision? So how do you sort of balance, and which one do you necessarily choose to go after first? Although you're slightly biased to answer this.
But I mean, and that's a hard question to answer, because I'm a big believer that most of these therapies and most of these interventions are really addressing the same issues, just from different angles. So I think it should be based off of symptoms and limitations and restrictions in life, and how we can address those immediately. I mean, if balance is so unstable and ambulation is so challenging, then a lot of times you're going to be working on the body before you're going to be addressing vision, because you need that bilateral integration with the body before you can further enhance visual skills. Hopefully, you're working with a great physiatrist, neurologist, neuropsychologist, who is kind of the team leader and directing you where you need to go. And there are some wonderful ones out there. especially at some medical facilities that are kind of going against the norms of practicing medicine from 30 years ago, and they're relying on the latest literature and research that suggests there are these treatments that maybe were considered alternative in the past that work, and the proof should be in the pudding with a lot of them. If patients are getting better, it must be working.
And speaking from personal experience, like I did vision therapy, vestibular therapy, some exercise therapy for autonomic nervous dysfunction concurrently. And I think that vision therapy can play a big role in helping your vestibular therapy along, because if you can't properly take in visual input, your balance is going to be thrown off because the systems are intertwined. And it's really just how much can you handle. And I think it's also a question of what's bothering you more. Are you back in the classroom? Are you trying to, just be able to walk down the hall without symptoms? Or like there's a different, you have to prioritize based on what you're feeling. So that was our final question. So Headway would like to thank everyone for giving us your time today. We hope you learned something. A big thank you to Dr. Bryce Appelbaum for donating his time. If you want to learn more about Headway or check out all of our great resources, please visit www.headwayfoundation.com. And so hope you guys have a great rest of your day. Thank you for joining us.
Thank you.